We're back at the annual meeting of Women's Cancer, a Society of Gynecologic Oncologists, and we're here with Dr. Powell. I'll have him introduce himself, but he just recently had a presentation on endometrial cancer I want him to talk about.
Hi, I'm Matthew Powell from Washington University in St. Louis. Myself and Dr. Sean Dowdy were just debating the conundrum of lymph node dissection for endometrial cancer. What's the most appropriate patient that needs this procedure performed? Despite the fact that we know a large portion of women are at risk for the disease spreading beyond the uterus, we still don't have a good handle on who benefits from having their lymph nodes sampled to really allow the best personalized medicine so we can target their therapies when it's most indicated. What we were debating this morning is, should those further studies be for all patients with endometrial cancer, just the lower grade patients with endometrial cancer, or just the higher grade patients with endometrial cancer, to do a randomized type study where half of them would have lymph nodes removed and half would not have them removed, and use more what we call traditional risk factors to help determine what's needed. The main area of controversy is, how can we help women with the least morbidity to them? We know there's morbidity taking lymph nodes out. They can have swelling in the legs to follow. Maybe up to a quarter of them will have what's called lymphedema, which can be a lifelong process. Couple that with a disease that, thankfully for most women, is more of a nuisance rather than a threat to their life. We want to do it, manage their problem with the least impact on their overall quality of life.
For a patient specifically who may be going through biopsy or knowing that they are being diagnosed potentially with endometrial cancers, what are some of the questions they should ask a doctor right now that would help them know where their doctor stands and just help them understand what's going on in their surgeries?
Great. You bring up a good point. When even the experts are having a hard time deciding what's the right thing to do, certainly a woman will have a hard time getting on the internet and trying to figure out what's the right thing for herself. So she really needs to find an advocate, and hopefully that advocate will be a specialist that takes care of these cancers. A gynecologic oncologist should always be at least involved in some of the decisions that need to be made. The problem we have is you may not know really what needs to be done until you're actually in the operating room getting a look at what the tumor looks like once the uterus has been removed. And we'd like to be able to handle everything during that one surgery rather than sometimes patients have to having multiple surgeries to figure out what's the most appropriate therapy for them. So involvement of specialists, I think, is a necessary part of management of this cancer. Thankfully, most people can hopefully be treated without having to have extensive surgery.
For a woman that has gone through the surgery, and can you speak to women who have had dissection and those who have not? What are some of the things they should be asking their doctors? What are some of the things they should be talking, hopefully, to their gynecologic oncologists about as follow-up as they hopefully see a good long-term prognosis? But what are some of the things they should look at, whether it's with dissection or without?
Yeah, so without lymph node dissection, typically it's just recovery from a normal hysterectomy. So we don't usually have a lot of long-term complications such as swelling in the legs, nerve damage, vascular problems. With lymph node dissection, there can be difficulties that can develop over time. Sometimes that will represent swelling. Sometimes that actually can be painful and actually require therapy. And that therapy can consist of compression hose, so they actually have to wear fairly tight compression garments to help keep the fluid from building up in the legs. These are things they should look for over time. Now, that's specifically about the lymph nodes. Now, but that information the lymph node gives us really can allow us to triage women very appropriately if they're at high risk for the disease coming back. Say there is cancer in the lymph nodes, they typically would be treated with either a combination of radiation and chemotherapy or one or the other. And those decisions about how best to individualize treatment for our patients is complex. And I think that it really involves experts trying to sort that out. And even among the experts, there's still a debate about what's the right thing to do. That doesn't mean we don't have any idea what to do. It means we're trying to fine-tune that still. That was part of the portion of our debate today, was really to say, how are we going to study this? How are we going to study it most efficiently and get these answers for the women in the future?
Last question, very personal opinion question. Obviously, you not a perfect prophet, but if you're going to guess in the next few years, where are we going to be in understanding this decision? How long is it going to be until we have real data to define which is the right direction with surgical care of endometrial cancer?
Well, we've also recently completed a large trial, over 4,000 women enrolled in what's called a molecular analysis of endometrial cancer, where we did full surgical staging, and now we're trying to figure out, can we actually move to more of a breast cancer model where they can do a test on the tumor itself to determine what the risk of that tumor coming back is. That's really allowed cutting down on the amount of lymph nodes they take in breast cancer, that and kind of understanding the drainage patterns of breast cancer. We hope to move to a more sentinel lymph node type basis and a molecular characterization of these tumors that allow us to really personalize their care. So if I look to the future, that's what we hope to see.
Thank you very much, Dr. Powell, for sharing with us and for all your hard work. Thank you.